ahead. So, hello, everybody. Before we start today, I want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day and on whose traditional territories our work takes place. While we meet today on a virtual platform, we can take a moment to acknowledge the importance of these lands, which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. So, my name is Autumn Sipis. I am the project manager for the Canadian Coalition for Green Healthcare. And on behalf of the Coalition and Peach Health Ontario, I would like to welcome you to today's webinar, or Cut the Carbon Beyond the OR event, Environmental Stewardship in Emergency Medicine. So throughout the event, please use the chat function for any technical issues you may be experiencing. You can use the Q&A function for any questions you have regarding the presentation, and our panelists will be pausing periodically through their presentation to answer some questions, and then we'll also have a longer Q&A period at the end of the event today. We are also recording this presentation, and the recording will be sent to all registrants and will be available on our website and YouTube channel at a later time. So presenting today, we have Loukam Ghouti and Dr. Henry Swoboda. Loukman is a fourth-year medical student at Dalhousie University with a strong interest in sustainable healthcare. He is actively involved in research and advocacy projects at the intersection of clinical care and planetary health. And then Henry is an emergency physician at Queen's in Kingston, Ontario, with additional board certifications in is it
Sorry,
addiction
addiction medicine, medical toxicology, and
medicine?
lifestyle medicine. Sorry.
Thank you. And he's an active member with CAPE and the OMA Greenest Health Group, as well as Kingston General Hospital and KGH Emergency Department Green Teams. Is the mistake in the spelling of addiction? I was like, is this some weird medical term? All right. Anyways, so I'm gonna hand things off to Henry and Lukman to get us started.
Perfect. Thank you, Autumn. So hi, everyone. My name is Loukam Ghouti. As Autumn said, I'm a medical student based in Halifax, and my co-presenter is Dr. Henry Swoboda, based in Kingston. Today, we're talking to you about something that affects every emergency department, whether urban or rural, and that is the environmental footprint of the care that we provide, and how we can reduce it without necessarily compromising patient outcomes. This was a project that was done in collaboration with a lot of other great folks who are mentioned below, some of whom are on this call. Next slide, please. We have no conflicts of interest to disclose for this presentation. This slide here looks at the learning objectives. First, we'll look at the environmental footprint of the healthcare sector. We'll walk through some of the realistic changes that emergency departments can implement. We'll also touch on the leadership structures that can make initiatives successful. And finally, we'll look at how clinicians can integrate low-carbon, evidence-based decision-making into everyday care.
And so I just wanted to talk briefly about what is, sustainability. It's not just talking about making everything low carbon. Of course, that's one of the first things, but we're in kind of a crisis of all sorts of materials. And so we need our system to be making circular use of materials, being steady state, not necessarily needing to grow, and being resilient, local, equitable, and intergenerational, having to integrate all of these issues into what it really means to be sustainable. And the reason for this is, as I said, that we are in this kind of crisis of all sorts of biological systems. This is a list of the planetary boundaries. I had to fill in the ocean acidification one because they haven't made a graphic for it yet, but that is a boundary that we've also recently crossed amongst all of these other planetary boundaries. And so not only are we dealing with carbon issues, but we have to deal with sustainability within all sectors.
Healthcare should be without harm. And this sentence really kind of captures the essence of why we're here. Healthcare exists not only to heal, but it exists to heal, but it unintentionally harms the systems that try to protect the health of our patients. And so if we accept that healthcare should be without harm, then that principle must extend beyond the patient in front of us. It should also include the communities that we serve, the air that we breathe, and ultimately the planet that sustains us. And so to put this into perspective, the healthcare sector contributes about 5% of global greenhouse gas emissions, which is equivalent to the output of 514 coal-fired power plants running nonstop. And so if healthcare were a country, it would rank fifth worldwide in total emissions, just behind the United States, China, and India. Emergency departments in particular are among the most energy and waste intensive environments in healthcare. They operate 24/7 with continuous lighting, air exchange, and equipment running around the clock. And because of the high patient turnover, single-use items are often the norm. And so that means that the emergency department is both a major contributor, but also a major opportunity for change. This table here is from a paper by Healthcare Without Harm, and it shows the per capita healthcare emissions in 2019. Globally, the average emissions per capita for healthcare activities was around 0.28 tons of carbon dioxide equivalents. India has the lowest per capita emissions of all 43 nations that were included in this study. Meanwhile, the United States is the number one emitter in both absolute and per capita emissions. Canada is also among the top emitters, producing just over 1 ton CO2 equivalents per capita per year. And so our healthcare sector in this country produces about 4.6 to 5% of national emissions, which is about 5 times more than the aviation sector. So if we ask the question, where do these healthcare emissions come from? What are the carbon sources? Healthcare produces greenhouse gases throughout the entire chain, not just inside the hospital. And so the GHG protocol is the global standard for categorizing and reporting these emissions. It divides them into 3 scopes. Scope 1, which is direct, Scope 2, which is indirect energy, and then Scope 3, which are kind of all the other indirect forms. And so understanding where these emissions come from can help us target the ones that we can actually control in the emergency department. Sorry. So looking at how climate change translates into health issues we see in the emergency department every day, climate change affects health through multiple interconnected pathways. So things like rising temperatures, extreme weather, changing ecosystems are not kind of distant or abstract. They're showing up right now in emergency departments across Canada. And within this chart, each color segment represents a different driver of health impact. So for instance, the red section represents rising temperatures, which can lead to heat-related illnesses like heat stroke and dehydration, but also cardiovascular strain and renal stress. So this increases mortality for patients who have heart disease or older adults. The other section to look at is the green section, which looks at changes in vector ecology. So things like warmer, wetter conditions are expected to expand the range of vectors like mosquitoes and ticks, which can lead to diseases like malaria and Lyme, among others. And what we're seeing now is that previously tropical diseases are appearing in more temperate regions. And these illnesses are moving farther north every year. And so in the interest of time, I won't go through kind of all of the parts of this chart, but the summary is that climate change acts as a health threat multiplier. And that's a phrase that I really like because it kind of captures things well, in that climate change amplifies existing medical and social vulnerabilities. And so every system we treat, from respiratory to cardiovascular and even mental health, are affected.
And then moving on, just as we'll be being called to do more due to the medical and health effects of climate change, as well as climate-related disasters, those disasters and the changes, things like floods, power outages, supply chain disruptions, extreme weather events, extreme heat events, etc., will put a stress on our healthcare system. the system itself, both the people who work in it as well as our infrastructure and our supplies will be threatened. And so as we talk about sustainable systems, reusable equipment, lower energy care, better public health, etc., those are things that are more resilient to climate impacts, and are things that we need to start thinking about, because we won't be able to provide the same carbon and material intensive care in the same way that we're doing it now in the future. And so when we start looking and thinking about what does a future system, look like, is, well, it has to start out with high quality care, right? We can't just throw our emphasis on quality out the window. But again, it needs to be low carbon, climate resilient, and sustainable. And Cascades has come up with a kind of graphic here. These are kind of the six domains of quality in this wheel here, but that the idea that environmental sustainability needs to be at the center of all of our decisions. That you can't have healthy people on a sick planet. You can't have high quality care that is environmentally unsustainable. Because if it's unsustainable, it's degrading the environment, it's harming people. And again, we want to have this goal of healthcare without harm. And so the idea that we must be having environmental sustainability ingrained in all of our decisions is a key one. And so that's why we put together the toolkit. The idea is to equip BDs with actionable and evidence-based strategies to cut emissions while maintaining care quality. And we kind of have 5 domains. We can split our pieces up into different ways depending how you shuffle them, but that's kind of how we organized it into these 5 separate domains here. And so the first domain is in leadership, creating a green steering committee within the emergency department, helping develop policies for energy waste and procurement, tracking metrics and reporting progress regularly, and developing a culture of micro to macro sustainability focus. The idea is as with everything, is we measure what we care about, and we care about what we measure. And so even if you don't have concrete things that you're be able to move forward on the moment, the fact that you have a leadership group coming together, you're developing policies that start to shift the culture and focus on our energy and waste and all of those things, and we're starting to track those metrics, as well as emphasizing just a departmental cultural shift in our sustainability focus, will allow kind of future changes to happen as well as develop this infrastructure to develop the changes in the future. And it kind of builds off of this idea of these social tipping points. You may have heard of other climate tipping points, melting of the Arctic sea ice, decreasing the albedo effect, and increasing climate change, etc. But the way that we have to combat those and change the business as usual culture of inertia is that these little steps, bit by bit, the idea is that as we start making small amounts of progress, eventually we recruit more and more people into the cause of developing a more sustainable system, and we reach this tipping point where the activation energy is low enough where we can actually make a change. And this has been put forth within by Lancet Planetary Health, by a number of kind of the heavy hitters in Canadian emergency medicine that's climate focused, between Courtney Howard and Joe Vipond and other people who have been active in CAPE, and I'm sure the other authors, some of which I'm familiar with as well, are very well focused on this as well. I point them out as their emergency department focus. And they point to this idea of engaging social tipping points within the hospital setting. Again, starting at this micro level, looking at perhaps your own food, but also the food that's served in the hospital and the department, and the energy that's used, and transport, and all those things, and focusing on getting some concrete wins, using that to help shift further practice, to get more power and increase our strategy to again move towards healthcare sector decarbonization and an eventual kind of more macro level kind of decarbonization across the board is the goal. And so you don't necessarily have to see how step 1 gets to step 2 and gets to final decarbonization, but starting with the little things can help us engage in these social tipping points. One positive factor is that we're starting to see accreditation standards integrate in environmental sustainability. And so I've seen that shift in my hospital, where it had been difficult to engage with administration in some degree. But now that we're seeing these things to be requirements, now we're able to get more people involved, and hopefully we'll be able to start making greater changes. Although there were some great things in works even before. And so as those things are coming about, potentially those are things that can be used to advocate for support and resources for a green committee. And so, we'll pause there for now on kind of the leadership and the intro and climate kind of intro part, and see if anyone's got any questions or comments or anything that they'd like to discuss at this point. See if we can, I can't really see the chat. I don't know if anyone else is monitoring it.
Can I just jump on
Yeah.
without putting my hand up here, Henry?
Yeah.
And thank you both so much for what you've done so far. Yeah, you have the social tipping points on here again. I really do like this one. Do you want to explain for those who might not have seen this before? You've got from A to B, the line goes down, and then it kind of has a little camel hump there. What's the camel hump? What are those people underneath the camel hump?
Yeah. So, I mean, this is kind of like a chemical reaction you might you might remember or might have blocked out from organic chemistry. Kind of ideas. The way I think of it is that, if you see this ball, the Earth, rolling down a slope, well, it can get caught in this kind of middle state there where there's another hump that has to go over, and it doesn't have the activation energy. It doesn't have the energy. We don't have the power to make our cops actually be productive and make real change at this time. We don't have the energy to change our whole healthcare system right now. So, what are the actions that we can do? It can be thinking, okay, what does our decarbonized state look for? But also, what are these social tipping interventions? What are the smaller things that may not make that big of a carbon impact, but they can decrease that activation energy? And that's what the people kind of pulling that hump, pulling down the energy. It's the idea of like when smoking was so common. Everyone was smoking. Doctors were smoking in their offices. Smoking was everywhere. And then, there's more and more things happen. You couldn't smoke in bars anymore. Can't smoke in restaurants. Can't smoke on airplanes. Then suddenly everyone knows that and talks about how dangerous smoking is. And suddenly it's this thing that isn't happening, anywhere near as much as before. The kind of whole society is kind of turned against it. And there's been, these huge gains as far as that's concerned. And so you kind of reach these tipping points by kind of, by chipping away at that activation energy and kind of increasing, your ability to do more. Okay, here we go. So, barring any other questions, I guess we'll move on to supply chain.
Yeah, so when we talk about environmental stewardship, the supply chain is one of the bigger or the biggest levers that hospitals actually control. One of the simplest ways to reduce emissions is to shift from single-use items to reusable items when it is safe and appropriate. So things like gowns, drapes, sterilizable tools, these changes often save money as well as carbon emissions. And looking at point number 2 there, when hospitals negotiate contracts, sustainability needs to be part of the conversation. So that includes reduced packaging, recycled materials, and suppliers who can actually report their environmental footprint. These small decisions can scale hugely when applied across a system. Partnering with sustainable suppliers who offer take-back or recycling programs is also a means of reducing emissions. It can put some of the responsibility back on the manufacturer. Life cycle assessments can also help us compare products based not only on cost or convenience, but also on their total environmental impact from manufacturing all the way to disposal. And then finally, standardizing supply orders across departments can help reduce over-ordering as well as waste and multiple shipments. And so supply chain is a big piece, but the good news is that a lot of this is within the control of the departments and procurement teams and falls within that scope 3 that we had talked about previously.
And I would say, just for an example of a way of a tipping intervention might be, you can't get people to 100% prioritize sustainability in their procurement, but even just getting it on the list of things. Okay, we're going to weight sustainability in procurement by, a couple of percent, whatever. It's on there. People are talking about it. They have to measure it. Then we start talking about, okay, how do we up our emphasis on sustainability? And that will allow us to kind of create more changes and things. So you can start with a small change, again getting it integrated into procurement decisions and work on more for the future. Some things that we can work towards procuring in the emergency department again are these reusable things. Some of them are very much supported by these life cycle assessments, right? Where we can say, okay, what's the overall investment in a disposable metal suture instrument tray versus a reusable one. And so some hospitals, the NHS is kind of ahead of us in doing a lot of this work and are moving towards reusable suture instruments, right? The instruments are typically higher quality, they're repairable, and they can be sterilized without any issues. They sterilize instruments in the OR all the time. There's no kind of infection control issue. And so some places are working to implement such reusable suture trays. We throw ours out all the time, and it's a negative both for the environment, but it's kind of a moral injury part as well. I feel bad every time I throw away all these metal instruments. And again, that maybe can help be a personal or social tipping to say, okay, this reusable stuff, this sustainability is something that I care about. Reusable tourniquets. Here in Ontario, Life Labs has moved to using reusable tourniquets, one of our main providers. And I talked with a phlebotomist there the other day, and they said, yeah, they're working great. We just wipe them down, with the cloth, and it's been sorted out. There's no issues with infection control there. They did say that occasionally someone has a problem where it's it's a little bit better to use a disposable tourniquet, and they still have them there. And so this can save tons. I mean, we use a tourniquet on like every patient we're putting an IV in, and it creates all this waste. And so we can talk about that. Speculum, same as suture trays. Again, there's no infection control reason why we must be throwing out all this plastic from speculums. And so thinking, how can we actually use these things, and how can we actually make it sustainable? Also, from a budgetary standpoint, there are some potential gains depending on what your costs for sterilization are considered. And so, in the toolkit, we kind of put together this formula to try and say, okay, how many should you stock? How do you start making these decisions? Okay, I want to do this. I want to stock suture kits. How many do we need to stock? How much is it going to cost us every year? And will we actually save money on this issue? Because there's certainly benefits to the environment, but if we're throwing out usable materials, there may be cost savings to be had as well. So we can pause there on supply chain and procurement, and see if anyone's got any questions as far as that's concerned. Yeah, supply chain.
Why always me? So just a comment for people who may not know that, of course, this is a national webinar, but in Ontario, 90% of the purchasing for hospitals is now done by Mohawk Medbuy. And Mohawk Medbuy does have sustainability metrics in their purchases, which is great news. And then there's the other 10%, which is done by hospitals. For anybody interested, we do have a sustainable procurement group that meets every 2 months on a Tuesday. I think it's actually next Tuesday from 3 to 4. Anyone is welcome to come. And we actually host that with Supply Ontario, which is obviously Ford government, but they are interested in this because they have the Bobby program. Basically, build in Ontario, buy in Ontario, and we're doing things locally. It naturally lines up with our objectives. I won't go into any more depth there, but thanks so much for that, Henry and Loukam, and I love your formula.
Great. All right, yeah, thanks. No, that's great. Maybe I'll join the procurement webinar. That's helpful. We're trying to move towards the reusable suture trays in my emergency department, and
Yeah,
it's a
great,
process.
great.
But you work with the sterilization folks. You figure out what you can procure, and you go from there. So,
Yeah.
all right, moving on to transportation.
Yeah, so this is another section of our toolkit, and transportation is one of the places to make meaningful change, because even small shifts can help reduce emissions significantly without affecting clinical care. And I will admit that our guide does focus quite a bit on e-bikes, but our aim is to update the guide for traditional active transport infrastructure and storage in future iterations. But advocating for and supporting staff who want to bike or use e-scooters by providing charging stations and safe storage is a simple but powerful intervention. But beyond just bikes and scooters, advocating for sidewalks and safe crossings, as well as protected paths around hospitals, can make it easier for staff, learners, and maybe even some patients to get to the emergency department sustainably. We can also cut emissions just by changing how we meet. Virtual meetings can reduce commuting and inner site travel, especially in regional systems where staff are often moving between campuses. And finally, no idling policies outside the emergency department can help reduce localized air pollution. So things like ambulances, patient drop-offs, staff vehicles that often idle for extended periods of time that can directly affect patients who have asthma, COPD, and other cardiorespiratory conditions. So it's a small policy change that can ultimately have a big impact.
Yeah. I think the other thing that I think kind of can belong in here in clinical care is other opportunities for virtual care as well. Um, if we can deal with some issues, we can triage them. We can get them referred without a patient drove for hours to come to get a referral to neurosurgery and then drove back to see me the other day. And did I need a physical exam? We had imaging. It depends on the condition, right? But are there ways that again in our public healthcare system that we can better allocate care so people aren't having to travel so far, particularly in remote areas? Is a question that I have in my mind. It's certainly a big thing, and I don't know how to do it, but I think we need big ideas. Anyone have any other thoughts on kind of transportation and ways that it can impact our emergency department care? Hearing none, we won't let
Sorry,
Miles
Henry,
to log in.
did you see in the chat there was a question
Oh,
about the formula for the initial investment considered a quote safety factor unquote, which I presume adds a bit of extra padding as a backup. How would that number be determined, i.e., the reusables?
yeah. Yeah, that was just kind of at your best guess, like saying, um, saying, okay, our usual, like, figuring out your daily use. You say, well, how many kits do we order each year, and divide that by 365. You could potentially look at, is there variability in week to week, but there's, do you really need to crunch all the data on that, or you say, okay, well, we can turn these around in a matter of hours, so we don't need to stock that many more. Some days maybe we use 20% more, something like that, so let's stock that many. It was not necessarily based on science, but it's based more on your idea from your department, how much variability there is in your usage of whatever materials we're talking about. I'm just thinking suture kits here, but whatever it might be is just trying to guess, how much variability there might be.
Okay, and something in the Q&A from Caitlin Points from Unity Health. So I worry about pushing virtual care without fully understanding the environmental impact of the systems, i.e. data centers that support this. I don't know the answer myself, but virtual is not zero impact.
Sure. No, I think that's a great point. And that's where we start talking about, like, yeah, we need to be talking life cycle assessment. Is not just jumping on whatever seems like a good idea, but saying, okay, is this really going to be better? Again, or if we're providing inferior care and now people are having complications because of it, or you have to do the virtual, but then they have to come in anyway. How much does that actually save? There's a lot of questions there. I agree. I think it's something worth investigating, not necessarily something that we're saying, that there's a great implementation strategy available for us right now. All right. So we move on to physical space.
Yeah, so physical space of the emergency department is also full of small targets for change. As we'd mentioned before, the emergency department operates 24/7, and it's one of the easiest wins is powering down equipment that is not in use. Things like monitors, printers, computers in back workrooms, certain procedural tools like a POCUS machine. Um, Switching to LED and smart lighting is another intervention that can reduce carbon emissions. And one of the studies we looked at showed that switching to LED lighting alone can save about 520 tons of CO2 equivalents annually, and turning off idle screens adds another 800 tons saved per year. So quite a substantial amount. Linen is also surprisingly carbon intensive because it's washed, dried, transported, restocked constantly. So simple changes like reducing unnecessary linen use, not automatically replacing everything during each room turnover, using water responsibly can help reduce the carbon footprint without compromising cleanliness. Um, Promoting responsible imaging use. Imaging is a major contributor to healthcare emissions. A CT contributes about 6.6 kilogram equivalents of CO2 and MRI about 20 kilograms. So promoting responsible imaging can help not only improve patient care, but also reduce unnecessary resource use. And this kind of aligns perfectly with the Choosing Wisely recommendations. And then finally, maybe the most important piece is building a culture of climate literacy with staff. So when staff understand the impact of everyday decisions, even small things can change. So this includes, education, signage, and also integrating sustainability into quality improvement conversations.
Great. Yeah, any questions on that one? Miles, if you wouldn't mind checking the chat, I'm not able to see it. Or Lukeman, I don't know if you can see it. I can't.
Yeah, look, yeah, happy to provide that role. We have a few nice hellos in there, which is lovely, and seeing some new people and having someone checking in from Mali, which is pretty amazing. And then our friend Krista Mahoney from Newfoundland and Labrador, who I think is making more of a point here, really appreciating the concept of small initiatives having an incremental impact that can matter in the long run, as I do get some pushback on, quote, does this target really matter, unquote. So sort of more reinforcement of that concept. And I did see Lisa Van Lint. I don't know if she had meant to pull it out for some reason. I'm not. She did have a question there about the LCA of sterile water, greenhouse gas of sterile water. I do have an idea about that if you are not aware, Henry and Loukman.
No, I'm not sure.
Yeah, I don't know the numbers.
So the work that's being done in a few centers across the country, I'm just aware of it on the endoscopy side, and that's part of our national plastics project now, is trying to scale that work up. The fact that, hey, we drink tap water in the morning, we drink tap water in the afternoon, why do we need sterile water to flush during endoscopies, colonoscopies, right? So some hospitals in the country, I'm going to say at least 4 or 5 now, have gotten rid of sterile water, not completely, but for most procedures. There is a study I have seen that did look at the footprint of that. I'm never great at remembering the name of the authors of these sorts of things, but there is a study out there internationally that looked at the footprint of getting rid of the sterile endoscopy bottles. And Lisa, I'm just, I know they broke it down by different categories, and it is possible that in their study they did not include the sterilization number, but I can look for that for you. And Lisa asking, are there other areas we can reduce sterile water? That's a great point. So they're doing it in GI. Are you using sterile water in emerge? I suppose would be the question. If so, for what? Is it necessary in every
Yeah.
case?
I guess I would say, yeah, we can, talk a bit about clinical practice. And, in our clinical practice, I think where we tend to use sterile saline or water is irrigating wounds. And, to my knowledge, the data is pretty clear that it's safe to use tap water for wound irrigation. So a lot of times I'm closing up lacerations. Um, uh, I'll numb somebody up, and then we'll bring them right up to the sink and just put on the tap and let it flow nice and hard onto their wound and irrigate them out real that way, and then get them back to their bedside. Versus potentially bringing a basin of tap water as well as a syringe if they're not ambulatory or whatever. And so yeah, the data seem to show that that's a safe practice as well. And to me, that's the number one way that we can kind of have that impact in our clinical practice.
Yeah, amazing. We need to talk later, Henry. I don't know if that's happening, and if we could find some good studies on that, it'd be great to scale that up.
Sure.
Devin Clark, how are you doing, Devin? Haven't seen Devin in a while. Similar to the question on virtual care not being zero impact, has there been any study on the impact of AI data center power use as healthcare continues to reach more toward AI to solve our problems? I have heard that in the USA, many coal power plants have remained online that were scheduled to come offline in order to satisfy AI data center power needs. Yeah, I think this is probably a question for anybody on the call right now. Yeah, I don't know, Henry and Loukman, if you have any inside knowledge there.
Yeah, I'm not certain about about studies, particularly in medicine, but with its growing role everywhere. And at Queens we've got an upcoming symposium on AI in emergency medicine, and then that's one of the questions that I want to ask is that what is the risk versus benefit of this, as but that applies to kind of across the area. I mean, we know the energy costs are huge, and so we should be expecting significant clinical benefits from our use of AI, not just convenience, is the way that I, in my personal opinion, would phrase it. But I'm not aware of studies.
Yeah, absolutely. And so then if we're able to use AI in a way that decreases ER visits and decreases admission days, then it becomes a really complicated equation, because those are the big CO2 users, is the use of the system. So boy, that's a big study someone needs to do. I've also know some engineers at McMaster that are talking about using those power centers and the heat that those centers create to heat buildings. I don't know what you do with them in the summer, but so lots of thought there. Devin, do you have any insights on that at all before we go to something else? And he can either jump on and chat, or he can put that in the chat. So one thing before I get to the next question, Henry and Loukman, how much more presentation time do you need?
I can take as much, or I could get through it in 10 minutes. So it's,
Okay, fine. So I'll give you one more question here, and then I'll
All
let you carry on. From Krista, there was an Atlantic Provinces conference in PEI last week, which focused on emergency medicine and planetary health. Working on a few follow-up actions from that event, including a potential green team for EDs and placing Choosing Wisely patient handouts on antibiotics, bronchiolitis, head CTs, etc. So making those visible. So some good ideas there. Devin, following up here, he saw a great video by Practical Engineering about this on YouTube. It wasn't specific to healthcare, just AI in general. So that's the resource for people to look at that's in the chat. and Loukam giving us a resource here looking at intersection of AI and healthcare sustainability. Gosh, I got to look at that one, Loukam, something that I've thought about a lot. So I'm going to pass it back over to you guys to carry on.
Great. So, yeah, moving on, we'll talk a bit more about our clinical practice, and we'll start with maybe some, I don't know, less controversial ones, and then things that I'm certainly an advocate for on kind of shifting the role, our role in the emergency department to as much low carbon care, which tends to be preventative. But first, we'll talk a bit about waste segregation. So you can see here, based on this study and a variety of other studies and our own personal, data, is that there's certain kinds of waste that are extremely energy inefficient and create a lot of carbon footprint, particularly the sharps and our biohazard waste. And so one thing that we can do is be very clear, work with our environmental services teams to determine what really needs to go in biohazard and what doesn't. Do not be throwing out our masks like in this picture into that are unsoiled masks. Do not belong in the biohazard bin. They can go into regular low temperature incineration, and it won't be a problem. And then what things go in there, not be throwing out non-sharps in with our sharps, and those can go in regular garbage. So making sure that we have the knowledge for how we're supposed to be segregating our waste, and ideally an implementation strategy with, again, this is part of our talking with ED staff about it, putting up signs, those sorts of things is one way that we can work a bit differently in our clinical environment. One other thing we can do, you guys may have heard about the climate impacts of our inhalers, our aerosol inhalers. I've seen numbers anywhere from 170 to 290 kilometers in a gas car from a single inhaler. And so how do we prescribe inhalers that are more climate friendly? It can certainly be difficult for children or for people with extremely low lung capacity who can't activate some of the other inhalers and take a deep breath with it in. But for the vast majority of our patients, soft mist or dry powder inhalers are an excellent alternative. And I don't have the time to determine which inhaler does what and what's on formulary or not. But luckily, Cascades has figured it out for us. There's a website, inhalerguide.ca. You can select your province, you can select the medical condition, asthma, COPD, the patient's age, and it'll put examples of what's appropriate for the patient and their medical condition on there, and what their carbon impact is. One change that I've made, should we be prescribing anything for like bronchitis? I don't know. The evidence is questionable, but I think a lot of us do it. When someone's kind of wheezy, but they don't have asthma and you want to give them something to try for their cough, I prescribe terbutaline. Bricanyl is the brand, terbutaline. It does not have climate impact, so that's an easy thing. It's something that isn't much evidence-based for our care in the first place, but we still want to be able to give the patient something. That's something we can do. We can select these inhalers as listed off of here, and depending on what's on formulary. And then, talking with patients about bringing their inhalers. If there's not an inhaler disposal program, you could work with your pharmacy to see if they can do one, or direct patients towards that. You actually save quite a bit of those greenhouse gases by bringing them to inhaler disposal program as well. So working on an inhaler strategy and educational campaign for the rest of the people in the emergency department. And then considering, I think we had a large move towards inhaler usage during the worst of the COVID pandemic, and we've yet to, at least in my department, swing back to using more nebulizers. I think this is a place that's ripe for research as well. What is a life cycle assessment of the plastic of a nebulizer compared to giving out a single inhaler? And does it depend, does someone use the rest of the inhaler at home? Does the inhaler get discarded? How many times is the nebulizer used? I think it's a great question, but certainly for patients who are going to be getting admitted, and if you can figure out a strategy to send their nebulizer with them, it would be less greenhouse gas emissions. So nebulizers, disposal, and appropriate use of inhalers is something that we can maintain clinical quality with no issue, while still decreasing our carbon footprint. And so one reason why we have to work so hard to decrease our carbon footprint here in Canada is because we are doing a lot of highly expensive, high carbon care. This graph tells us that our life expectancy is better than the United States, who is getting less for more expenditure from their health system. But we're getting about the same amount for much more money than a lot of other countries, a lot more carbon. I expand that to as well as those numbers tend to track. So we need to learn how to do more with less. We need to get good healthcare outcomes with our limited dollars and our limited carbon outputs. So we have outcomes similar to Spain, Portugal, and Costa Rica, ideally with carbon and healthcare expenditures similar to Costa Rica than Canada. And we have to do that by thinking about what can we do, what low-tech medicine. The way we're doing medicine right now takes 5% of our greenhouse gas emissions. We can't provide this kind of medicine. There aren't technologies to remove carbon from everything that we're doing. And so we need to figure out what sort of preventative care, low-tech medicine can we do to prevent Earth ecosystem, much less healthcare system collapse. And so we're talking about a shift in the way that we think here. And I think there are some things that are simple to do that people without additional board certifications as myself, that's what I've tried to learn by learning about these additional things, is what can be implemented in the emergency department by an average physician, what requires specialty training. And so I think there's things that we can all do. And part of the reason for it is that our lifestyle in Canada is generally poor. I extrapolate here American data that only 3 to 5% have a healthy lifestyle, being a non-smoker, healthy body weight, 5 servings of fruits and vegetables today, and 150 minutes of physical activity a week. And this results in 63% of Canadians being overweight or obese, 20% of Canadians having fatty liver disease, a disease that was like unknown, 30, 40 years ago. Now 20%, 1 out of 5 people have because of our lifestyles. And we know that about 20% of our deaths are due to just dietary factors. And so if we focus not at all on these preventative strategies, when we have our teachable, reachable moment in the emergency department, we're missing out on our ability to impact about 80% or so of chronic diseases that are lifestyle related. And so I think it's important that we start to think about how do we counsel, how do we do some more of this more in the emergency department, because it can be high yield for health. The American Thoracic Society has come out with a practice guideline on smoking cessation in 2020, and they say first line is varenicline over nicotine patch and bupropion. So for anyone initiating treatment, give varenicline or Champix. For tobacco-dependent patients with psychiatric conditions, right? That's been a lot of people's concern. There was some signal early on, it's been resolved. They still recommend varenicline as first line. And they say in tobacco-dependent patients who are not ready to discontinue tobacco use, but they just want to cut down, they want to be a bit healthier, they're willing to accept a medication, we recommend varenicline. So figure out what the prescription for varenicline is. There's a bit of a dose pack, and we can put it, send it out, but that people start with 1 dose and they escalate it. But people are 2 to 2.5 times more likely to quit if treated, and this has been done in the emergency department. Not in the emergency department. Again, we see this around 2 to 3 times more likely to quit if they get varenicline. In the emergency department, it's been shown that counseling in the emergency department for smoking cessation was as effective as performing in the outpatient setting. And that what we can really do is some motivational interviewing, and just a main part of that can be connecting a patient's current illness to smoking, which increases their quitting success. You're here with chest pain, you're here with shortness of breath, you're here with any sort of vascular issue, you're here with wound healing issues. Talk with them about smoking cessation, and consider prescribing varenicline and increasing your ability to do that. The BC clinical practice updates had a great session on this that you could look up on how to prescribe varenicline. But it's a thing we can do out of the emergency department. We should be talking to patients about the risks of smoking. In our guideline, we talked about Park's prescriptions. There's all sorts of data that show that decreasing cortisol, decreasing stress hormones. We're talking just 20 minutes in nature is enough to start bringing down your stress hormones. We recommend that 3 times a week. And we've got handouts. So someone comes in with mental health concerns, with issues with cancer, with history, hypertension or cardiovascular care. Talk with them about just spending some time in nature. low carbon. You can print them out a handout. You can have a 1 minute conversation about how, yeah, and it doesn't have to be hiking in the mountains. It doesn't have to be exercise. It's time in nature that's meaningful to the patient. So if they go and sit on a bench in a park, it's going to decrease their cortisol and improve their mental health. We are animals on this planet. We are evolutionary geared towards being around nature and trees, and our bodies respond better when we're in that environment. And it's backed up by data, and there are these sheets that you can print out to help you with it. We talked about the impact of diets, about 20% of Canadian deaths. The food system is also responsible for about 25% of our greenhouse gas emissions. About 80% of that is from livestock production. And in our crisis of everything, we know that vegan diets are responsible for about a quarter of the greenhouse gas production, a third less biodiversity impact, and less than half the water use. So if we can be helpful in shifting people's diets, we can help save the planet, but we can also help save our patients as well. And so if you haven't heard of this Eat Lancet program, it was a group of experts in nutrition, health, agriculture, and they came together and they said, what is a healthy diet that will also sustain the planet? And they came up with this flexitarian type diet that has a half your plate fruits and vegetables, a quarter whole grains, and a quarter proteins, primarily plant proteins. They say you can have a serving of meat a day and a serving of low-fat dairy a day and still be healthy and sustainable. So that's what, you don't have to be dogmatic about it. A healthy diet, and it's supported by our Canada Food Guide. So this is something you can point to your patients about. The Canada Food Guide says, eat more fruits and vegetables, half your plate fruits and vegetables, a quarter whole grains, a quarter proteins coming from plants more often. That's what our Canada Food Guide, which was the first one that came out without industry input, came through. And they say make water your drink of choice as well. And so there's resources for this. Again, I like these Plant-Based Health Professionals UK handouts. They're on all sorts of diseases. They go through some other lifestyle stuff. I emphasize for the patients, again, don't have to be dogmatic. Just because it says plant-based, this is the way you want to shift. It's okay to eat some animal protein. The data show that the less you eat, the healthier you are. It's okay to still eat some, as in the Eat Lancet diet. But that's why I say it's okay to eat some, but you want to shift your diet to be more in this direction. Plant-based doesn't mean entirely vegan, not a scrap of animal protein. It has to be culturally appropriate, etc., for the patient as well. We can talk with the patients about exercise. Going from a sedentary state to at least some amount of physical activity is probably the number one health thing that someone can do to improve their mortality. Again, go to Exercise is Medicine from the American College of Sports Medicine. They've got all sorts of handouts, a brief discussion about improving physical activity for all these conditions, osteoarthritis, low back pain, and of course our cardiovascular disease are things that we can have a brief discussion and then give them a handout, right? We don't have time to do all of this for too long, but we can have a brief discussion, give them a handout, and potentially refer them to treatment. So a plant-forward nutrition physiotherapist, exercise therapist. In Ontario and BC, Aroga is a lifestyle clinic that you can refer to. I refer to patients to there all the time out of the emergency department. And Lifestyle RX is in Ontario, BC, and Alberta. And it's geared at metabolic diseases, primarily diabetes, but any sort of metabolic disease. And it's a whole program. They're covered by provincial health insurance. And you can, get a patient interested, give them a referral to treatment. That's this kind of expert kind of model. And so I guess I'll pause there. We've got the recommendations from Choosing Wisely. I think some are controversial, or less controversial. Some are more. But I'd be happy to hear what people think about how we can be spending a little bit more time with our patients, which is low carbon, and trying to improve health outcomes with some of this preventative care, as well as inhalers or waste segregation. Any thoughts on any of that?
Yeah, great stuff. I've got a couple of chat questions for you here. One from Spencer Graham in BC. Lots of unnecessary waste in our biomedical waste bins. Our environmental support service team did biomedical waste audits last year, found that 58% of the contents by weights of the non-anatomical bio waste bins were actually safe to put into garbage or recycling. So that is simply reinforcing something you were just pointing out. Any ideas how we do better on that? And that could, look, put it in the chat if you have answers. I mean, I suppose people have signage, et cetera, but may not recognize the environmental harms and probably increased costs, just kind of being lazy there. I'll just carry on with the next question. This is about inhalers. Working on green inhalers in my ER sites, stocking terbutaline now. At your site, do you have terbutaline listed as an order set? That's one question. And two, do people prescribe it as back-to-back or just terbutaline 0.5 milligrams can repeat Q5 minutes?
For us, I'll say at our site, we're focusing on the kind of prescribing of it, and we have not yet integrated it into our clinical care. So I can't speak to that directly. We're still thinking that ideally, we could use nebulizers for patients who are sicker, and have not integrated terbutaline into our clinical care. Although they're to my knowledge, there's not evidence that shows that salbutamol is superior to terbutaline. So I think it's a reasonable thing to do. Probably for our less severe patients, and moving on to salbutamol again, nebulizer for sick patients. I think that's a reasonable clinical pathway.
Right. So it is 12:57. Thank you both so much for your time and expertise today. I'll give you 30 seconds to gather your thoughts for any final comments that you have. And during that time, I am going to just mention something that Lisa Van Lint has added, which is for waste segregation, who has mandatory waste segregation training for staff, either e-learning or in person. And so that's being answered in the chat. I don't know that you need to speak to that, or people just want to look at the chat. Spencer's got an answer there. So any final comments, Henry and Loukam? Great job today, and thank you so much.
Yeah, I just wanted to finish with the fact that small, consistent change is what creates system level impact. Things don't have to be multi-million-dollar projects to make a difference, and that the most effective initiatives start out small.
Yeah, and I guess I would just say that our current way of doing things is how we ended up in the predicament that we're in, and so that we must necessarily reach somewhat outside of our comfort zone in order to actually see change. And so we need big ideas about how to actually accomplish that. So we need to keep working towards that.
All right, great. So reach out to us if you have any questions or follow up or want to volunteer. We always need volunteers. And have a great day, everybody.